Thank you, Diego. You will ask him questions when he's back on the panel. Since he called us all boring, what do you think? All right? So I'm doing my little bit to not be very boring, Diego. And I appreciate the talk because it really sets the tone very well for this introduction to the panel. What I want to do, and I think it echoes what Diego said, let's begin with the patient in mind and move away from tools, as we have been thinking and doing for so many years, to more holistic solutions where tools fit into an overarching framework. So my focus is primarily going to be on diagnostics, but I think that's also a part of the problem, that we think diagnosis separately from treatment and that they are not meshing into something cohesive. So I will try and also talk a little bit about treatment as well. And we know patients struggle, and we're going to hear more about our patients when they come here on the panel. And here are some big ticket items that we know are issues already. One is the whole issue of the so-called missing patients and the fact that people have major access issues. Secondly is the long, complex pathways to TB care and diagnostic delays in many, many countries. The broken cascades of care, which we are starting to see as we do more and more of these. Challenges in getting decentralized care closer to homes where people live, rather than running all the way to reference facilities and cities. Limited access to new tools. Even if we R&D them and we put them out on the market, patients are not getting them at the level that we would like them to receive. And then lastly, the fact that lots of patients are incurring all sorts of costs trying to navigate this health system. So let me show you some quick data on each of these access barriers. I think all of us agree that this missing numbers of 4.3 million, every passing year, the number of missing patients seems to be getting more and more and not less and less, which is really very strange. And we know that the so-called missing patients is probably made up of two groups. One is the genuinely undiagnosed, which probably is an issue in some settings. And there's probably another group, which I will show you data on, where they're really not missing, but they are in the non-TB program sector. Whatever that sector might be in that country, that's where they are. They are actually seeking care, and they are actually being managed in whatever quality that treatment might be outside of the TB programs. And then we also know poor access for MDR is just so striking that not even 1 in 5 MDR patients are even remotely close to being correctly diagnosed and managed. So that we know is already an issue. Patient pathways, and the more we do them, especially from a non-TB perspective. In other words, if you just look at general health seeking and then look at TB health seeking, you start to realize that TB care seeking is not very different from general care seeking, because TB symptoms, after all, are very non-specific: fever, cough. They're very, very ordinary. So people do whatever it is that they normally do if they fall sick. And this, to me, is striking because the foundation worked with Christy Hansen and her team to look at 11 countries. So it's a very crude snapshot. Obviously, you need to dive deeper into each country if you want to address the issue. But to me, the first very interesting point is, if you look at initial care seeking, general care seeking, almost 30% are going to the private informal sector. Another 30% is going to the formal private sector. I mean, massive numbers of people around these countries are first starting in the non-TB program sector, which is totally logical, totally intuitive. They are going to whoever their first contact primary care providers are. That could be your Sangoma in your village. That could be your pharmacist around your house. Wherever they're going, they're going. And this is not a trivial number. This is not just India, okay? India is obviously dominated by the private and the informal sector, but this is across 11 countries. Very substantial numbers of people are rumbling around the system looking for a diagnosis, and I will also show you data that they are not getting a TB diagnosis at that level. Why? Because there is no diagnostic for TB at that level of the health system. We don't have a magic dipstick. We only have microscopes, and they're primarily sitting in the NTPs. Outside of the NTP, the ability of primary care doctors to diagnose TB is very low. And so they do what they know best, hit people with broad-spectrum antibiotics, and hope like hell that whatever they have will disappear. Right? That is the empiricism that we consistently see in primary care practice. Multiple rounds of non-specific therapies and antibiotics until 3-4 visits have gone, and somebody's bell goes off and say, okay, I've done everything possible. Now this is beyond my ambit. I'm now sending you to a TB center. That's why 2 months have to pass, and 3-4 providers have to be seen before TB is first picked up. What the transmission consequences of all of this, we can debate and discuss, and we know that's clearly an issue. And that's exactly what the analysis shows. At the L0 level, there is no diagnosis for TB. And that's why we end up with this massive missing numbers of people, because the system is not outfitted to diagnose at the primary care level outside of the NTB. Cascades of care. So this analysis, just to, in my own head, I see them as being very different. Pathways to care tells me where they enter the system, where they navigate, and where they end up, but it doesn't quite tell me what the numeric drop-offs are. If I want to know what the numeric drop-offs are at each stage of the cascade, then I have to switch to this sort of an analysis that HIV folks, our HIV community has been doing for decades. This is the first ever published TB cascade of care for India that we worked on with Ram Subbaraman and colleagues, published in PLOS Medicine. This is the India's public sector cascade of care, only public, okay? India's private sector, nobody has a care cascade because nobody even notifies, right? So we don't know what the drop-offs are, but just let's go with the public sector in India for a second. You begin with the total number of estimated cases, which we think in India is somewhere around 2.8 million. We still don't know for sure because nobody's done a prevalence survey. But then you see how big the drop-off is. These are people who are reaching the diagnostic centers in the public system and then actually getting diagnosed. So you already lost 500,000 people at just this stage. 500,000 people have already been dropped off at the earlier stages of the diagnostic pathway. Once the Indian public program picks up TB, by and large, if it is drug-sensitive TB, it does a pretty darn decent job of linking them to care. Once TB is diagnosed with smears, then the whole machinery kicks in. They give you a box with your name written on it, no chance of a stock out. They send up somebody to visit your home, they register you, they do a very decent job, they link you to a DOTS supervisor, so on and so forth. And so once treatment is started, by and large, people make it to the finish line, but then we also found there's a bunch of people who develop recurrence after TB treatment is completed. Long story short, you have almost only 40% of drug-sensitive cases reaching the finish line in the Indian public program. And India has recognized this. If you look at the new National Strategic Plan, there is a clear-cut plan to do care cascades on a regular basis and plug some of these gaps that have been identified, which is the beauty of this sort of an analysis. It tells you where you should be really focusing on, and we can clearly see diagnosis is the biggest problem in the Indian care cascade. Exactly true for HIV, true for many other diseases that you look at. Now, here is a cascade of care for South Africa. This is also being written up for publication. There was a call earlier this week to discuss that. I'm just showing you the MDR cascade in South Africa, which the DOH and Gates Foundation and their consultants looked at. MDR care cascades, I also have one for India in the same paper. MDR care cascades, as you can all imagine, is like falling off a cliff. It is so bad that not even 20% of patients make it to the finish line. No surprise here, but it's substantially worse than the drug-sensitive cascade of care. Drug-sensitive, it already is bad, but MDR is a complete disaster from a perspective of the number of people that we lose during the entire process. This is the care cascade for latent TB, okay? This is from a group at McGill University, looking at not just one country, but a meta-analysis of large number of studies. And boy, look at the drop-offs in latent TB, right? Only about 1 in 5 patients with latent TB. With all the money that we throw at latent TB in the rich world here, only 1 in 5 make it to the finish line with latent TB. So every single cascade, drug-sensitive, drug-resistant latent TB, is broken in every place that you look at. And HIV, on the other hand, has set 90-90-90 as their goals for their care cascade, and they're consistently looking at the district-wise, subgroup-wise, and constantly trying to plug that to bring it to the 90-90-90 that they want to see in their care cascade. Okay. Secondly, how decentralized is TB diagnosis and treatment? So I had a bunch of my students work on this. Some of you in this room have probably helped us with this analysis. We essentially contacted the highest TB burden countries, and we asked them a very simple question. In your healthcare system, and we use the same terminology that we've been using at the foundation, L0 is the community or the village, L1 is your primary care health center, L2 is your district level, L3 is your state level or national level or a centralized facility, okay? So each of the level, we ask them, what do you have for triage? Do you have a chest x-ray? If you have a chest x-ray in your health system, where is it? If you have smears, where is it? If you have DST, where is it? And if you have tuberculin as a proxy for latent TB diagnosis, where is it? And we ask the same questions for therapy. Where can you treat drug-sensitive TB in your health system? Where can you treat MDR? Where can you give isoniazid? So on and so forth. To make this very short, just look at the amount of red. Red means it doesn't exist. Look at the amount of red at the L0 and L1 level. In other words, with the exception of sputum smears and HRZD, virtually no country has the ability to deliver care at the primary care level. Forget the community. Community, nothing exists. Okay? We all know that. There is no tool, nor in some cases, health systems are able to do follow-up in the community. In other words, they treat you at a higher level, and then they're willing to follow you up at your house level or your community level. But by and large, this picture suggests that TB services in most countries start at the district level or higher, with the exception of HRZD and sputum smears, which is decentralized to the microscopy center level. Now, this has got great significance because it tells us that a patient will not get decentralized care and must necessarily travel to the district level or higher for pretty much everything except drug-sensitive TB. And that means bouncing to multiple centers is part of their life. There is no other way that they can pull it off. And that tells us where the drop-offs may also be happening at the cascade of care. That they seek care, but when they're told to go to another level, they just don't show up. Or they show up late, they have to restart the diagnosis all over again, so on and so forth. We all know access to new drugs like bedaquiline and delaminid, right? That picture from MDR-TB stat is pretty stunning because as opposed to how much the eligibility is, what fraction are receiving. Let's look at diagnostics for a second. This is the most recent data from Cepheid, which tells us we have now reached about 23 million cartridges, right? That is the end of 2016. Now that curve of GeneXpert access looks pretty steep. Let's not forget, that's for a 6-year period. If you take that 23 million and divide by 6, you get a sense of what the annual usage is. So the better approach would be to not just look at the GeneXpert trend, which does look pretty darn impressive, and instead anchor it against smears. So a couple of years ago, we published an analysis where we looked at the smear to GeneXpert cartridge ratio. In other words, if you have to do 1,000 smears in your country for every GeneXpert cartridge you're using, that tells me that that country is hardly using GeneXpert. On the other hand, if you almost at a 1-to-1 ratio, using one GeneXpert cartridge for every smear, that means GeneXpert has really penetrated your healthcare system, right? No surprise, when we did the analysis in 2014, that's the square blue, okay? Virtually all countries were doing hundreds of smears for every GeneXpert, with the exception of South Africa, which we all know was an early adopter and really started pushing GeneXpert out. Now we've repeated this analysis, it's unpublished, but we now contacted the next year and said, have these countries moved in the right direction? In other words, are they using more GeneXpert today than they used in the past? And the answer is very positive. You can see virtually in every country, the ratio is tending towards 1. In other words, more and more expert cartridges are being used in countries which makes me very happy that the trend is in the right direction. But the reality today is most NTPs have rationed the use of GeneXpert only for selected high-risk groups. Even if they have the technology sitting there, they're unwilling to widen the net and allow more patients to access the test. They've reserved it for HIV-infected people and for people who failed therapy, and in some cases to children, but not broadly accessible. And so you have to ask yourself, although the trend or the ratio is in the right direction, why are countries underutilizing a technology that they've already invested in, right? This is a fabulous new study from Vanderbilt looking at multiple countries, okay? They looked at several countries, and you can see the map of all the countries they looked at, and they say, do they have expert? Then they asked, are the expert cartridges actually being used? And the data are stunning because the amount of expert used was in only 5% of TB HIV co-infected patients. I'm not talking about everybody, folks. I'm talking about HIV co-infected patients. Even in them, even with the expert in place, the utilization of expert was ridiculously low in something like 18 countries. And this is, to me, a stunning issue that countries have invested in it. The box is lying there. Somebody's willing to run the damn machine, but the cartridges are still being rationed very carefully to the extent that a lot of people who could be benefiting are not benefiting. We ran an entire discussion on this in GHT Online on underutilization of good technology and why that actually happens at the country level. So the conclusion of this study is expert utilization was low, even though the majority of sites had access to the test. This is like India. India has 600 GeneXpert machines, but they are still tightly walled off, and it's still not accessible widely to the private sector, which actually could be, which has tremendous absorptive capacity to diagnose patients, because that's where a lot of patients are actually seeking care in the Indian health system. So I want to now just end by saying we know what the problems are, right? I don't think we need any more evidence. What are the solutions? And that's exactly what I want our panelists to think about. How do we go from the messy cascade to something that looks complete, right from the time somebody is symptomatic? Can they get a rapid triage test? Can they get a decentralized molecular test? And can they get a more centralized DST, sequencing, LPAs, or whatever that might look like? Can they get a shorter regimen? Can they be sent home with an adherence technology package, a whole suite of methods to improve adherence? Can there be electronic notification and tracking? Can the whole thing be connected within a digital ICT system? This is no longer a single tool, but an entire test, treat, track, and follow-up package, which I think we all agree is desperately needed, kind of like the companion diagnostic talk we heard. It's no longer test separate from treatment. It's all meshed into a single thing. And this is a very nice graphic from the foundation, which says we need solutions across the entire value chain. And I will ask my panelists to tell us what type of solution might work best to plug the gaps that we are seeing in the cascade of care. And lastly, I also want to, the foundation recently released a call through GCE for integrated diagnostics, right? And the thinking was really that diagnosis no longer can be thought of in any one thing. We said point of care, point of care, point of care, but we realized there's only some things we can do at the point of care. Not everything needs to be done. There will come a time when we have to refer the patient or a sample to a district level facility. And maybe for some things like sequencing, we probably don't need to go that far. We can centralize it, provided there's a good sample transportation system supported by ICT. So it's good to now see this as diagnostic at every level of the healthcare, connected seamlessly through sample/patient referral systems that are all working cohesively. So to me, these are all parts of the solution, and I will now invite my panelists.